So addiction intersects with gastroenterology and hepatology in a way that is both common and often underrecognized. From a hepatology perspective, alcohol-associated liver disease is now one of the leading causes of chronic liver disease in the United States and the leading indication for liver transplantation as well. Opioid use disorder also contributes to hep C transmission through injection drug use and leads to significant motility disorders and functional GI diseases. What makes this especially important for clinicians is that substance use disorders are treatable, yet they remain underdiagnosed and undertreated in GI and liver practices. Um, Gastroenterologists and hepatologists are often in a very unique position to identify unhealthy substance use early because patients may present with related complications before they ever engage in addiction care. Most of all, addiction should be viewed as a chronic medical condition that directly affects any other medical outcomes. So routine screening, early intervention, and coordinated treatment in that regard can significantly improve both substance use disorders, outcome, and organ-specific morbidity and mortality. Unhealthy alcohol consumption plays a central role in alcohol-associated liver disease because alcohol directly causes structural injury to the liver through several key mechanisms such as toxic intermediates, oxidative stress, and activating inflammatory and immune pathways within the liver. Clinically speaking, though, AUD has some overlapping with ALD, but they're not the exact same disease entity, meaning we still do not have the clearest pictures of what subset of AUD patients or ALD patients develop another disease and why. And that's why we need to shed more light on the concurrent incidence in research and clinical standpoints. I would say the first and foremost is under recognition. Many patients are not routinely screened for substance use in GI and hepatology settings. And as a result, unhealthy substance use often goes unidentified until significant organ damage has already occurred. Another challenge would be the over-reliance or sole reliance on self-report, which can be affected by stigma, fear of judgment, or in transplant setting, concerns about transplant eligibility. We do introduce structured screening tools and objective biomarkers and try to use them as much as possible. But again, they're not consistently used in clinical practice across the nation. On the management side, care is often fragmented, meaning patients may be seen in hepatology clinics without access to addiction services. And also, many clinicians feel uncomfortable prescribing medications for alcohol and opioid use disorder, especially in the setting of liver cirrhosis, despite growing evidence, very strong evidence that is safe, even in the setting of liver cirrhosis. And of course, particularly in substance use disorder, social and structural barriers such as unstable housing, limited access to care, and co-occurring psychiatric diseases, these all can make sustained engagement very difficult. So overall, I say the biggest clinical challenge is not a lack of effective treatments, but rather identifying patients early and integrating addiction treatment into routine care. Yeah, chronic opioid use disrupts GI motility, including esophageal dysfunction, gastroparesis, and constipation, and narcotic bowel syndrome. Opioid use disorder also can contribute indirectly to liver disease through hep C transmission with IV use. Um, Cannabis is also most strongly associated with cannabis hyperemesis syndrome, which is recurrent severe vomiting after prolonged heavy use. And synthetic ones have been known to link to hepatotoxicity. Yeah, one of the major gaps we identified in our work is the disconnect between how common substance use disorders are and how inconsistently they are addressed in GI and hepatology practices. As I said, routine screening is not universally implemented, and even when substance use is identified, evidence-based treatments remain significantly underutilized. There's also a knowledge gap among specialists. Many gastroenterologists and pathologists have limited training in addiction medicine, and uncertainty and lack of confidence about medication safety in patients with liver disease, because this is not like thoroughly covered in existing training. From a health service research perspective, we need more data on integrated care models, strategies to improve treatment uptake, and the impact of addiction treatment on long-term liver outcomes, including transplant outcomes and survival outcomes. So that's really what our review aimed to address, to highlight addiction care as a high impact opportunity to improve GI and liver outcomes. So the most effective way to manage this very complicated issue is through truly integrated multidisciplinary care, because treating the liver disease without addressing the substance use doesn't change long-term outcomes. So in practice, this means bringing care together rather than working in silos. For example, some institutions have developed integrated clinics where hepatologists and addiction specialists see patients in the same setting so that they could increase access and engagement. Others include addiction medicine specialists and transplant committees, so substance use treatment become part of the longitudinal transplant plan. And another important strategy is meeting patients where they are. For example, using non-invasive fibrosis tools like elastography in addiction units to identify liver disease early and connect patients to hepatology care. So those kind of models really reflect the message of our review that addiction and liver disease should be managed as a single coordinated condition, and that integrated care is essential to improving both survival and long-term liver outcomes.